To our IC, our first talk would be, is ACIOL still relevant? And it would be by Dr. Shamik Prafull Mokadam. He is basically a vitreoretinal surgeon trained from Arvind Eye Hospital and at Nagpur, doing a phenomenal work. So Dr. Shamik, please.
Yes. Good afternoon, everyone. At the outset, I would like to thank Dr. Bhavan sir for letting me be a co-instructor for this instruction course. Actually, this particular topic was given to Dr. Smita Upadhyay, who's one of our retina consultants in Nagpur, but for some reason she couldn't come, and I'm presenting this. And just to clear the doubts that I'm a retina surgeon, I don't do these very much. So I'll just go ahead. Is ACIOL still relevant is the topic, and I'll start off with why and where do we have inadequate capsular support, and what do we do in such conditions. Capsule is damaged or dislocated or inherently weak, and if it is damaged, it is mainly because of trauma or complicated cataract surgery. There may be dislocations or there may be zonular adhesions at places with severe infections or inflammatory processes, and inherently weak in conditions like Marfan syndrome, homocystinuria, Wheel-March-Sani syndrome, etc. So in such cases, we have an algorithm where we plan what to do when we have aphakia with open posterior capsule. If there is a 360 degrees intact anterior capsule, we can very well place an 3-piece IOL in the sulcus, with or without optic capture if possible. If there is very minimal rim remaining or there is no rim remaining, then we have all these other options, including iris fixation, ACIOL, and scleral fixation. And in scleral fixation, we have sutured, Yamane, glued. Someone has recently spoken about, published about net technique for PCIOL placement. So these are the various ways that we can take care of aphakia. Coming to anterior chamber or angle supported IOLs, the first one was implanted by Baron in France in 1952. And with advances in technology, newer multiflex design, which had an open loop flexible haptics and an anterior vaulting of 0.5 millimeters by Dr. Kelman was introduced. And that is the one which we are still using on a regular basis. The contraindications are unhealthy corneal endothelium, uveitis, absent or insufficient iris support, pediatric cases, and eyes with shallow anterior chamber. Ideally, we should measure the angle-to-angle measurement on as a OCT-based measurement. But then, when we don't have such equipment tools, we can measure the white-to-white diameter with the help of a caliper and take a IOL which is 1 mm greater in diameter, so that we can place this IOL safely in the anterior chamber. But if it is anyway smaller or too big or something, it may cause malpositioning, misalignment, and things like that. We also need to do a thorough vitrectomy. We need to have a peripheral iridectomy, which should be done away from the haptics, otherwise the haptics may cause further damage. And it is better to use a dispersive viscoelastic as is preferred to prevent post-operative IOP spikes. The ACIOLs are vaulted anteriorly, ensuring the correct orientation helps in placing the IOL properly. There is something called as an upside-down syndrome, in which may lead to chronic iritis, cystoid macular edema, pupillary capture, iris adhesions, corneal decompensations, and UGH syndrome-like conditions. So we have to have a proper orientation of how we place the IOL. To place the IOL, it is better to use a lens guide, and the location of haptics is also important, because if we place it in the periphery and we are not taking care that the iris is getting tucked in the foot plates, we may end up having other complications. And if at all we happen to see an oval or peak pupil, it is a sign that the iris tissue or vitreous may be tucked in the angle. Sometimes even the foot plates or the haptic may get broken, like in the picture that is not very clear, but then it is seen in that picture on one side. Calculating the power for the ACIOL, it's easy if it is if we have done a biometry previously and considered that it is going to be ACIOL, it's easy. We just take that IOL power and place it. If not done that way and it is a complicated surgery, you have to implant the ACIOL on table. We need to reduce the IOL power by 2 to 3 diopters as calculated for the PCIOL biometry. Pseudophakic bullous keratopathy is the most common complication. Could be because of mechanical trauma at the time of surgery, intermittent contact between the cornea and the intraocular lens, natural age-related endothelial cell loss, and constant inflammatory reaction that may happen with all the ACIOLs. The management is explantation of the IOL and doing a penetrating keratoplasty. UGH syndrome or uveitis glaucoma hyphema syndrome is one of the common conditions associated with ACIOL. We get to see iris transillumination defects, pigmentary dispersion, micro hyphemas or hyphemas, and raised intraocular pressures. This condition is commonly seen with ACIOL more than iris fixated, and the least it is seen in posterior chamber or scleral fixated IOLs. Management is topical steroids, topical anti-glaucoma medications, or systemic anti-glaucoma medications, and for the hyphema we could do cycloplegics for ciliary spasm, limited activity, and head-end elevation. Surgically, we need to remove the IOL or try to reposition it and exchange explantation and or exchange for recurrent episodes of hyphema or uveitis. Secondary glaucoma could be a pupillary block, secondary angle closure glaucoma, prevented by a surgical PI and managed by a laser PI also. So is it relevant? I would like to put some negative points. Not a physiological location for a lens. It is not friendly with the cornea or angle or iris. But then improved surgical techniques allow for posterior lens placement by iris fixation or scleral fixation. There are improvement in pars plana vitrectomy, so complications for ACIOLs are expected to reduce drastically. And ACIOLs provide visual improvement in 63% of complicated cataract surgeries. In small setups, it does help us. So ACIOLs are still relevant in developing countries, but are not expected to stay for long. However, where facilities of PPV are well developed, techniques for better IOL placement are also developed. Thank you. I would like to invite my retina colleagues for the VRSI this year, which is being held in Nagpur from 3rd to 6th of December 2020.
Thank you, Shamik, for covering the anterior chamber IOL. Yes, definitely anterior chamber is somehow going into, would be a past, I believe, basically because of the corneal problem, UGH problems and all those things. So what are the other options which we have in a case of a compromised capsule?